Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City, and welcome to Soundbites Cases. In this Soundbites module, we'll look at ultrasound for the diagnosis of soft tissue infections. Ultrasound allows for excellent imaging of the soft tissues and can be very useful in identification of soft tissue infections such as cellulitis versus abscess. In fact, ultrasound can be very helpful in identification of an abscess and determining if an IND procedure is necessary in the emergency department. Ultrasound can be very helpful in avoiding iatrogenic injury to vital anatomical structures in proximity of an abscess during an IND procedure, such as associated vessels or nerves, and can potentially decrease the complication rate associated with an ED-IND procedure. So let's begin with a clinical case that I think highlights the utility of bedside sonography for soft tissue infections. Our clinical case for today is entitled "To Cut or Not to Cut." Our patient is a 21-year-old male who presents to the emergency department complaining of pain and swelling to his back. On exam, he has erythema and swelling spreading across his lower back, and the area feels indurated with questionable areas of fluctuance. So the clinical question here is, do you blindly stick in needles to attempt aspiration of the pus, as this could be an abscess versus cellulitis, or do you blindly cut the area with a knife looking for liberation of pus? Or do you take the default position and discharge to home on Keflex and Bactrim, hoping that the whole infection resolves? There's now a growing body of literature showing that ultrasound can be very helpful in detection of soft tissue infections in terms of determining if an abscess is present versus cellulitis. Here's one of these studies, and this study enrolled 107 patients with soft tissue infections, comparing ultrasound to clinical assessment for detection of an abscess. The two gold standards were either presence of pus on incision and drainage of the infected area, or clinical improvement after antibiotics if an IND procedure was not performed. This was a study from Abscess Study in Academic Emergency Medicine by Dr. Squire and Fox in July 2005. The results of the study were very interesting. Clinical exam only detected abscesses with a sensitivity of 86%. Compare that to the sensitivity of ultrasound for detection of abscesses, which was much higher at 98%. Thus, the conclusion of the authors, emergency department ultrasound improves the accuracy and detection of abscesses over clinical exam. For this application, we'll want to use a 10 MHz higher frequency linear array type probe to image the superficial tissues of the skin. So now let's take a look at what normal tissue looks like on bedside sonography. Here are the depth markers to the left, and we can see as we scan through the skin that we have well delineated tissue planes. Now the fascia here goes down to 2 centimeters as shown by the hash marks to the left, and we can see the deep fascial layer, which is usually present at about the 2 centimeter mark. From 2 centimeters down to 4 centimeters, we can see the muscle layer, well indicated here as we scan through the patient's leg. Notice here that the fascia is well seen and has a very organized structure on bedside ultrasound, and we can actually see the little tissue planes within both the fascia and the muscle layers. So this would be indicative of normal skin without any cellulitis or abscess. Let's contrast that last video clip from this one with a patient who presented with a warm and angry area over the left leg. As we scan through the area, we can see that we have an area of cellulitis present on the leg. Notice that we've lost that usual tissue plane definition that we saw in the last video clip, indicative of normal tissue, and here all we see is a very angry and inflamed area of cellulitis. Notice that the fascial layer is now bulging and thickened all the way down to 4 centimeters, pushing down on the muscle layer. So this would be indicative of a cellulitis. Notice here, however, that there is an absence of any fluid collections within the cellulitis, so this would be best treated with antibiotics. In this next video clip, I'm able to capture the interface between inflamed and normal tissue. Again, we notice the deep fascial layer at about the 2 centimeter mark. Now we note the normal skin to the left of the video clip here with the well delineated fascial planes. But notice here towards the right the area of cellulitic skin, and notice the obliteration of the normal tissue plane seen within the fascial layer. And we can see there the interface curving down between the normal skin to the left and the cellulitic skin to the right. Notice also that the area of cellulitis pushes down on the deep fascial layer, so we have thickening of the fascia, which is often seen with an area of cellulitis and inflammation of the skin. As cellulitis gets worse, Edema can develop within the cellulitic area that can coalesce to form an abscess. Here we see a pre-abscess stage with severe cellulitis with coexistent edema. We notice here the deep fascial layer bulging down at about the 2 centimeter mark, and notice in the fascial planes we can see dark or anechoic areas of fluid surrounding the areas of the tissue here. So again, this would be a very severe cellulitis with severe edema, not yet amenable to incision and drainage, but this would be needed to be treated vigorously with antibiotics and elevation of the affected area. Here's an interesting video clip from a patient who presented with a rapidly growing area of redness and swelling over the leg. And as we note here, we can see the deep fascial layer at about the 2 centimeter mark. Now clearly there's a cellulitis present here as the fascia above the 2 centimeter mark looks disorganized and inflamed, and we can see areas of edema throughout the fascial layer. But notice here the area of dark or anechoic spreading edema at about the 2 centimeter mark, which is going to be very concerning for the presence of fluid spreading along the fascial plane in necrotizing fasciitis. This video clip shows all the sonographic hallmarks of necrotizing fasciitis in a confirmed case. The first thing we see is edema spreading all the way through the fascial layer all the way down to about the 2 centimeter mark. Also, we see the presence here of gas pockets located over towards the right, and notice as I scan back and forth we can see the classic comet tail artifacts off the back of the gas pocket. So edema in the deep fascia and gas in the fascia consistent with necrotizing fasciitis. Here's a different viewpoint from the same patient, and again we see the distorted fascial layer. Notice here we see the spreading edema coming out just about the deep fascial layer at about 2 centimeters, and we can see again the gas pocket over towards the right with its distorted appearance. So that deep fascial edema with the gas, very, very concerning and diagnostic for necrotizing fasciitis. And in fact, this patient had a rapidly progressive area of swelling and redness over the leg and had abnormal vital signs. To confirm the diagnosis of necrotizing fasciitis, a CAT scan was obtained through the patient's leg, and here we see the gas pockets that have extensively collected towards the medial aspect of the leg. So no longer are IV antibiotics going to be enough in this case of necrotizing fasciitis. Surgery must be consulted for an extensive incision and drainage in addition to the usual IV antibiotics. This video clip shows the classic appearance of an abscess cavity on bedside sonography. What we see here is a well-delineated fluid collection stretching from the skin down to about the 2.5 centimeter mark. Notice the classic appearance of an abscess cavity with its mixed echogenicity. There's hyperechoic or light areas mixed in with dark or hypoechoic areas. That's classic for the sonographic appearance of pus on bedside sonography. No longer will antibiotics be enough. In fact, we'll have to perform an incision and drainage to clear the pus out of the patient's skin to complete a cure. Now, pus can have different appearances on bedside sonography. This one has more of a hypoechoic or darker appearance on sonography, but we see again the appearance of the classic abscess containment. Now we can see here that this, again, it stretches from about the skin down to about the 2 centimeter mark. We note that it has a mixed echogenicity, although the hypoechoic or dark areas predominate. So there's a little bit more fluid in this abscess cavity. But once again, no longer will antibiotics be enough. We'll have to perform an incision and drainage to complete a cure for our patient. This video clip shows the sonographic appearance of a pilonidal abscess on a patient's back. And as we scan through the abscess cavity, we note that it has more of a complex appearance. We see that it has the classic dark or hypoechoic appearance of pus, but we see some light areas. And it's interesting that as we trace the confines of the abscess cavity with a small indicator arrow, we note that the abscess cavity extends from the skin down to 1.5 centimeters, but that within the abscess cavity we see some hyperechoic or light areas of pseudomembranes that have developed within the abscess cavity. So this complex cavity will need to be incised and drained to cure the patient. Here's an axillary abscess, and what I'm doing is pressing up and down with the probe. And as I apply pressure down with the probe, we can see the movement of pus within the abscess cavity, confirming that indeed this is an abscess that will need incision and drainage. So this maneuver can be helpful in distinguishing the presence of pus within an abscess cavity. And we can see the pus here moving from the superficial areas down to the deeper areas at about the 2 centimeter mark as I push down with the probe. So a helpful diagnostic maneuver in confirming a need for an incision and drainage on a patient. In this next video clip, this was from a post-op patient who developed a fluid collection that was infected. And what we see here, as I push up and down with the probe, the presence of pus that's moving back and forth with pressure along the fascial plane there. And we can see that we'll need to perform an incision and drainage to get this pus out of this patient's skin to allow for a complete cure post-surgical. So let's review a few potential pitfalls in abscess incision and drainage that can be avoided by the use of bedside sonography prior to any therapeutic procedure. Abscesses may be located very close to or involve critical anatomical structures such as blood vessels and nerves, and it's important to map out the abscess cavity and its relation to any critical structures prior to an incision and drainage attempt. High-risk areas for IND in the emergency department include the neck and the groin, and one should have a very high threshold for performing any incision and drainage into these critical anatomical areas in the emergency department, and really use ultrasound liberally prior to any IND procedure. A well-known complication is that after cardiac catheterization, there have been some patients who have been diagnosed with infected femoral artery pseudoaneurysms, and incision and drainage into this area can cause overwhelming hemorrhage. Other potential pitfalls in abscess IND that can be avoided by the use of bedside ultrasound prior to a procedure is that chest wall abscesses may occasionally track close to the pleura, and one can look at the depth of the abscess in its relation to the pleura to avoid going through the thoracic cavity and causing a pneumothorax during an incision and drainage attempt. Also, abdominal wall abscesses may track close to the peritoneal lining, and it's important to know the depth of the abscess and whether or not it's safe to perform an IND in the emergency department, and how deep you can go without violating the peritoneal lining. Also, one can identify lymph nodes and solid masses, which are structures to avoid in any ED incision and drainage. Here's a sonographic appearance of a pus cavity that's developed underneath the patient's chin on the anterior neck. And we're looking with B mode or grayscale imaging to the left, and we see the classic appearance of a pus ball. And now we're going to put Doppler flow on the image to the right. Notice that while there's speckling areas of vascular flow, that this is actually an abscess cavity and not a whole vascular structure. So it would be safe to perform an incision and drainage into this area in the emergency department, albeit preferably by an ENT surgeon if one is available. But we can see here that there's no large vascular structures immediately adjacent to the pus ball, so we could get into that pretty easily with a small nick of a knife. This next video clip emphasizes the point that it's really crucial to look with bedside ultrasound prior to an incision and drainage attempt in high-risk areas such as the groin or in the neck. Here we see two very important vascular structures that we must avoid during any incision and drainage attempt. Here we see the femoral artery and vein, and notice the pulsations with Doppler flow. So using Doppler, one can make sure that there's not a vascular structure within the field for the incision and drainage planned attempt. This video clip shows the classic appearance of a lymph node, which can be a pitfall when one is thinking that this in fact could be an abscess cavity. Note the classic appearance of a node, which looks like a lima bean on a hyperechoic or bright stalk, and we can see the stalk inferiorly connecting up with the node. As we scan through the node, we can see that it has kind of that lima bean solid appearance, very different from the abscess cavities that we looked at before. We can also see that there's multiple lymph nodes on this image, which is consistent with a usual infection pattern. Remember that lymph nodes are commonly seen within the femoral areas or within the anterior cervical chain, and must be avoided in any incision and drainage attempt in the emergency department. Here we see an abscess that's developed on the anterior chest wall of a patient. It looks like an egg-like cavity of pus collecting anteriorly. Now note other important structures here on this video clip, and as our eyes go posteriorly, we see the lung sliding back and forth just off the posterior aspect of the pus ball. So while we could safely incise this chest wall abscess, we'd need to know that that knife could only go into the superficial area of the pus and no deeper, so that it would not go through the thoracic cavity into the lung, causing a complication such as a pneumothorax. This video clip shows another potential pitfall. This was a patient who presented with a swollen red indurated area on the top of the shoulder. And as we scanned back and forth through the area, initially it looked like a pus ball, but on further examination it looks more like a solid mass. Pushing down with the pressure of the probe failed to give the appearance of the typical movement of pus within the cavity. This, in fact, turned out to be a solid mass consistent with a tumor that had spread from a patient's underlying lung cancer, something to avoid as a pitfall in an incision and drainage procedure in the emergency department. In conclusion, thanks for tuning in for the Soundbites module covering ultrasound for the diagnosis of soft tissue infections. I hope I've been able to score the points that ultrasound can be very helpful in discriminating a simple cellulitis versus more complicated infections such as necrotizing fasciitis, as well as identification of abscesses in need of a drainage procedure. Ultrasound can allow us to better map out a patient's anatomy prior to an invasive procedure and can potentially decrease the complication rate associated with I&D procedures in the emergency department. So I hope to see you back in the future as Soundbites continues.